donor for your patients. And if anything goes wrong, then we might end up selecting the wrong donor. So if we select the wrong donor, which means we give a wrong group, ABO group, to a recipient, we are likely to have a transfusion reaction, which can be very fatal. ABO incompatibility is an acute transfusion reaction, and it is very fatal. And so today's webinar, we just want to see some of the errors or some of the discrepancies that you can encounter while performing blood grouping and how we can resolve this. So by resolving it in the lab, we'll give you the insights on what you are looking for in case you encounter these particular discrepancies. So discrepancies can be as a result of technical errors. So the first thing you do in the lab when you encounter any discrepancy is to rule out any technical error. So you have to repeat the procedure carefully and following your SOP so that you capture any gap in the system. So if it is not a technical error, then you have to evaluate further. It could be due to the age of the patient, maybe they are neonates, and so therefore they don't have enough antibodies, and that's where you are seeing the discrepancies. Another reason could be they are elderly, or could be they are sickly, or maybe they are having diseases such as cancer and things like colorectal cancer. So in such cases, you are likely to have a discrepancy. These patients could also be immunocompromised. They could be multiple. So there are so many reasons as to why you can be seeing different results in terms of discrepancies. And discrepancies here, we mean your forward grouping is not agreeing with the reverse grouping. So it is encouraged that when you are doing ABO blood grouping, you do the two phases. So when you do both forward and reverse, then you are able to compare. And if there's a discrepancy, you'll be able to resolve that particular discrepancies and come up with a conclusion. But in case you are just relying on one phase, that is, you are just typing, let's say the forward typing alone, you'll go with that and you'll miss out in the one for the reverse. So with that, we look at the objectives for today. It is important to recognize disputes and results and how to basically resolve them, just as I have said. It is very important that you resolve this whenever you encounter them. So ABO system is the most important blood group in relation to transfusion. As we have seen, most of these has got naturally occurring antibodies, and these antibodies are potent enough to cause a transfusion reaction immediately, even 15 minutes after starting the transfusion. So you really need to be careful when dealing with the ABO. And then misinterpreting ABO discrepancy could be life-threatening to patients. So if you misinterpret and give the wrong blood, then you are likely to have a fatal case. The first slide will be reminding us on how to do the grouping, that is interpretation. Of course, we are well conversant with the procedure, so I'll just take you on the interpretation. So here I'm having typical 4 patients. Patient number 1, there's a reaction on the forward grouping. There's a reaction with anti-A, and there is no reaction with anti-B, and anti-D is reacting. So one thing that you must always put at the back of your mind when dealing with the ABO blood grouping is the Landsteiner golden rule. So the Landsteiner golden rule states that an individual will only have in his or her system antibodies corresponding to the missing antigen. So it means that if a patient is blood group B, then the antibody they'll have in their system is that is corresponding to the missing antigen, and the missing antigen in this case is A. So blood group B patients will only have anti-A in their system. So therefore, when you are doing the reverse typing for this patient 1, you expect a reaction on the with the B cells, because in forward typing we are using non-antibodies, that is anti-serous, to look for a non-antigen on the surface of the red blood cell surface. And then on the reverse typing, we are using known cells. These are known A cells and known B cells to look for non-antibodies in the in the patient plasma or serum. So therefore, the result for this patient is A as positive. And then with the case example for patient 2, they are blood group B positive, which means in the reverse, you will be seeing, in the forward, you'll be seeing a reaction with anti-B. And then on the reverse, you will see a reaction with anti-A, because if they are blood group B, they have got anti-A in their system. And on patient 3, where the patient is having both A and B antigen on their surface, in forward typing, you will be having both anti-A and anti-B reacting. The fact that they have both antigen on their surface, it means this particular patient lacks antibodies in their system. And so therefore, on the reverse typing, we are not likely to see any reaction. And finally, for a patient who is always as positive, they'll be having no antigen on their blood surfaces, on their red cell surfaces. So if they don't have antigen on their red cell surfaces, it means that they have got both antibodies now, because both A and B is missing. And so you are likely to see a reaction with A cells and B cells. So that first slide is just a recap. And then now we look at ABO antibodies. What are the ABO antibodies? Because they are the ones that plays a major role in ABO typing. One, they are generally IgM class of antibodies. So IgM, which means they react best at room temperature. And the time of appearance, generally present within the first 4 to 6 months of life. So that's explain why in neonates, you don't do the reverse typing, because they don't have, they have not yet developed the ABO antibodies, but the antigens are there, so you can do the forward typing. And then this one they will continue producing antibodies with time and reach the adult levels at about 5 to 10 years of age, and that will level off through the adult life. However, it will begin to decrease later years. That is when they're becoming older, greater than 65 years of age, the level of antibodies again tend to decrease. And not only decrease, even the reactivity of these particular antibodies will tend to decrease. So what is ABO discrepancies? So the ABO discrepancies in this case, it happens when there is no match in results between the forward and the reverse typing. So you are doing the forward and the reverse typing, and the reverse is giving you blood group B, and then on the forward you are seeing blood group O. So ideally you should have the same result. The interpretation should give you the same blood type. If reverse is O, then forward should also be O. And in case where you are now getting conflicting results, then that's what we refer to ABO discrepancies. So normally this could be technical in nature and can be simply resolved by correctly repeating the test. So we say that the first thing when you encounter a discrepancy is to do what? Is to carefully repeat the procedure so that you eliminate the possibility of technical errors. So you do that by carefully checking reagents with meticulous reading and recording of results. So problems that could be causing that particular discrepancy you are seeing, it could be associated with the RBCs. So if it is if it is linked to the RBCs, then that is weak reacting or missing antigen. Could be a possible reason. It could be there, like in the subgroup cases, where you are having A subgroup or even the B subtypes. You find that with the subtypes, they are weakly reacting. Yes, they are not strongly reacting like the main group, let's say A1, and then now you are having a patient with A2. So how a patient with A1 reacts with anti-serous is very different from how a patient with A2 will react with the same anti-serous. Because A2 is a subgroup, it is a weak antigen, and so therefore it will give you a weaker reactions. And then A1 is a strong antigen, and they are able to give you a very strong reaction. So when you are doing the typing, and it could be extra antigen, like in the cases of acquired B, you will explain that one further, or it could be a mixed field reaction. So mixed field reaction mostly in cases where the patient have been transfused and all that with a type, let's say they are blood group A, and then you've transfused them with O. And then in that process, they have received multiple transfusion with O, So remember, in the patient system, we are having both A cells and O cells. So the A cells, when you are doing your typing, will give a reactions. And if you take this under the microscope, you'll be able to see agglutination while some cells will remain unagglutinated. And that is what we refer to as mixed field reactions. And so if that is not the case, then the second problem could be associated with serum. And if it is serum, here we are talking about weak reacting stroke missing antibodies. You could also be having extra antibodies. Maybe the patients have got autoantibodies. So the technical errors are classified into three. One, they could be clerical errors. So clerical errors, you check at your tubes whether they are properly labeled. So mislabeling of tubes could be one cause why you are not getting the right results. So you have to look at that. And then patient misidentification. It could be you've interchanged these particular patients and therefore you'll be getting the wrong group. And in one of the phases, either forward or reverse. So you really have to carefully check that. And then inaccurate interpretation recorded. So it could be you've done everything correctly, but however, on interpretation, you are interpreting, especially with the reverse. You are there's a reaction with A cells with the reverse, and then you are interpreting it as A instead of B. So that could be also a reason. So you really have to look at that. And it could be transcription error. Maybe you did everything correctly, but on recording, you ended up typing the wrong thing. You ended typing blood group B instead of A. It could also so transcription and computer entry error, those ones are tied as one. And then the next group is reagent or equipment problem. So you have to look at the reagent. You also have to look at your equipment if you are using automated platforms. So it could be you are using expired reagent and maybe they have lost potency and they're not giving you any agglutination. And then using uncalibrated centrifuge, and so therefore they are giving you wrong speed and you are observing a false agglutination. And then contaminated or immobilized reagents. So the reagents, especially the cells, they could be immobilized, and so therefore you are not getting any agglutination. So you will really have to look at that. And then in correct storage temperatures, you are not storing your cells in the required temperature, and so therefore they end up getting light. The next one is procedural errors, where you might have failed or forgot to add a reagent, or you failed to follow your SOPs from the manufacturer's directions. The RB suspensions in correct concentrations. So you are having a prozone and postzone scenario where a prozone you are having excess antibodies, and then postzone you are having excess antigens. So if you are not achieving the zone of equivalent, then you are not likely to get agglutination. So you have to ensure that your RB suspension is in correct concentration. If it is 1 drop of the cells, then you do 1 drop of the serum or plasma. If it is 1 drop of the anti-serums, then you do 1 drop of the cells of the patient when you are doing your forward typing, and the other one when you are doing your reverse typing. So the cell buttons not resuspended before grading the agglutination. So immediately after centrifuging, what you will see is the cell button. So if you don't suspend, then you will read everything as agglutination, and you will end up having a wrong blood group. So you have to, we encourage you use the tube method. It is more sensitive and more accurate compared to this other method like the slides. In the slides, you might not really be able to see the cell button, and you might not be able to centrifuge. So follow your SOP when you are doing these particular procedures. But when you are doing centrifugation using the tube method, always remember to resuspend the cell button before you can read. If it is a true agglutination, then it will persist. And then if there is no agglutination, the cells will be resuspended. So as we have discussed, false negative reaction can be due to one, failure to add serum or reagents. You are maybe in a hurry, or you are not concentrating while doing the test, and you failed to add one of the reagents that is required for reaction, specifically either the serum or the cell. So you are not achieving any reaction, and you are having a false negative. When you use incorrect reagents or sample, so maybe you are used anti-B instead of Your tube you've labeled B, but whatever you put is anti-A. So you really have to look into that. Then cell suspension is too heavy or too light. That one goes with the post-zone and the pro-zone effect that we have explained earlier. Then inadequate identification of samples or testings. You've not labeled your tubes correctly. You're supposed to label them. Let's whatever carry A cells clearly read as A cells. Whatever is having B cells clearly reads as B cells. And also the patient cells should be correctly labeled so that you don't interchange the three. Those ones are very key because if you interchange, you might end up using the B cells as the patient and having the patient cells as the B cells. So that way you will really have a wrong results and you'll give a wrong blood group in the whole thing. Then next is false positive reactions. That one could be due to uncalibrated centrifuge, contaminated reagents, dirty tubes, or glassware. So ensure also that your tubes are clean and they are not contaminated, and your centrifuge is optimally working, and the ppm for those centrifuge have been done, and they have also been calibrated. So those ones which are associated with the forward grouping are mostly missing or weak antigen. It could be extra antigens such as acquired B, BA phenotype, Rolex formation, polyagglutination, and mixed field agglutination. So we are going to discuss this in details while looking at the discrepancies and the various types of ABO discrepancies. And then the ones that affects the reverse grouping include missing or weak antibodies. So these ones you're likely to see in newborns and elderly patients would have weakened antibody activity. So therefore, you might not see very strong reactions even with the forward typing, or patients who are suffering from hypogammaglobulinemia. They are having low antibodies levels in their system, or they lack the antibodies at all, agammaglobulinemia. So little or no antibody production. So this is mostly associated in, you are likely to see this in immunocompromised patients. And also cold antibodies for those ones who are extra antibodies, such as the cold antibodies, it could be allo or autoantibodies. And also patients who are having A2 subtypes and they are sensitized, like they have in their system anti-A1. So those ones are likely to give you very weak reactions, and you are likely to see a discrepancy in such kind of patients. So resolving weak or missing antibodies, what you have to do is you determine the patient's age and diagnosis. And we have seen how the age plays a critical role, because at least with the age, you will see, you'll have to know whether they are elderly or they are neonates. If they are neonates, they have not yet developed the antibodies, and that one will explain your discrepancies. If they are elderly, then you expect a weak reactions with their antibodies. And then you incubate serum testing for 15 minutes at room temperature. So when you experience that, you can enhance the reactivity by giving it more time. So you will incubate the patient cells, I mean the serum and those testing cells for 15 minutes. And then you read thereafter, spin and read thereafter. So if negative, in case that is negative, then what you do, you also have to rule out if these patients could be having either allo or cold autoantibody. So what you will do, you will put a portion of the serum testing again at 4 degrees Celsius for 5 minutes, and that one will enhance the activity. You put it at 4 degrees Celsius. So when you do that, then you enhance the activity of the cold antibodies with the autologous control. So the autologous control here is just put the patient cells and the patient's own serums. So when you do that and there's a reactivity, then that is an indication that that patient is having autoantibodies because they have produced antibodies that are able to recognize their own cells. So when you are doing investigation, reverse typing testing of neonates is unnecessary. We have explained that you don't need to do reverse typing for neonates because they don't have enough antibodies, and that's explained why if you are doing cross match, then you'll cross match with the mother's serum or plasma. Reason being, the antibodies in their system are those from the mother, those ones that have been passed through they have crossed the placenta, and so therefore they are in the system of the neonate. So in that case, you cross match with the mother's serum or plasma, so that you give them units that are compatible with the mother's antibodies. So with that, you are likely to avoid transfusion reactions in this particular group of patients. So you also have to record everything that you've done. Documentation is very key, and as quality dictates, if it is not documented, it is not done. For the my audible up to that point, we want to look at the categories of discrepancies. I'm clear. So the first category we are going to look at for discrepancies is group 1 discrepancies. And the group 1 discrepancies are between forward and reverse grouping due to weak reacting or missing antibodies. And they're the most common in nature. These are the ones that you're likely to find routinely while you're working in the lab. So in group 1 discrepancies, we are talking about where you are forward grouping and the reverse grouping is not matching. And this is due to either a missing antibody or a weak reacting antibody. So before you conclude that it is a discrepancy, you've already ruled out the technical errors, because you say that the first thing we do when you encounter discrepancies is to repeat the procedure carefully and ensure that you follow the SOP and the technical errors have been ruled out. It means you've used the correct reagent, you've used the correct cells, you've labeled your tubes correctly, and you followed your SOP correctly. And you've also done the interpretations correctly, but still you are experiencing a discrepancy. So in that case, now comes to group 1 discrepancies. So in group 1 discrepancies, you could be having a weak reaction or a missing antibody. And this one, you are likely to see in 1, newborn infants, 2nd, elderly patients, those patients who are having severe hypogammaglobulinemia, patients with lymphoma, or patients using immunosuppressive drugs. Also patients with immunodeficiency diseases, as well as bone marrow transplant. So, as we have explained, you resolve this one by eliminating all the technical errors, and then you enhance the reaction in reverse grouping. So an example of group 1 discrepancy is the one shown in this particular table. So if you see this, our grouping here, according to forward typing, the patient is O. Again, if you look at the reverse typing, the patient is AB, according to the reverse typing. So according to forward typing, what do we expect in this particular patient? We expect a reaction with both A1 cells and B cells, being that if this patient is O, according to the forward typing, the patient will be having both anti-A and anti-B in their system, and that will give us a reaction. So what happens to the missing? What happens to the antibodies in the system of this particular patient? Because these antibodies, they are either weak, they are not giving us a strong reaction that we can see, or forming agglutination so that you are able to see if there's a reaction. Or this patient could be a neonate, they don't have enough, they don't have antibodies in their system. They are yet to produce antibodies, the ABO antibodies, to cause a reaction. Or this patient could be suffering from hypo or agammaglobulinemia, where they are having no antibodies in their system, or either weakened antibodies in their system. Or this patient could be immunodeficient. So those are the things you look at. So how are you going to have deduced so many that can cause this particular reaction? So the first thing, you'll go back to your history of this particular patient, and then with the history, you are able to resolve. So group 2 discrepancies, those are discrepancies that are between the forward and the reverse grouping. and due to weak reacting or missing antigen. So these are rare. You are likely to encounter them, but that doesn't mean that you cannot encounter such. So here now you are having a discrepancy, but the reason is to a weak reaction or missing antigen. So this can be caused by one, a subgroup, as we had explained earlier. Subgroups, they tend to, the reason why subgroups have got weak reaction is because the enzyme that is formed is less effective in converting the H antigen. You should remember how the A and the B antigen is formed. For example, how is A antigen formed? A antigen is formed when the A gene encodes for the enzyme that is N-acetyl D-galactosamine transferase, which add the sugar N-acetyl D-galactosamine to the H precursor substance. And so once this one is done, you'll have the A antigen. And then the B antigen, on the other hand, will be formed when the D-galactosamine, the enzyme, add the sugar D-galactose to the H precursor substance to give us the B antigen. So in a subtype, you will find that, for example, A2, the enzyme that is formed is less effective and does not convert more of the H antigen. And also the antigen that is formed, which is the A2, is weak reacting compared to A1. If it is blood group O, then that is an arm of gene and does not add any sugar to the H precursor substance. So in this group O patients, what are we having on their red cell surfaces? It is just the H antigen that you are having on their red cell surfaces. So how is the H antigen formed? Therefore, the H antigen formed is the H gene will encode for the enzyme, which is the fucosyl transferase that add the sugar L-fucose to the precursor substance to give us the H antigen. If you are in India, or maybe you are in an hospital where you are dealing with Indian patients or people from India, you might have another group that is the Bombay phenotype, where there they don't even have the H. So the Bombay phenotype, the H gene there is recessive and it does not add any sugar. And so therefore they are only having the precursor substance, but they lack the H antigen. And they will react with all the red cells, including the O cells, the A cells, and the B cells. So back to this, having known why this weak, the antigens could be weak, especially in the subgroup. So it could be subgroup of A or subgroup of B. Also patients with leukemia and Hodgkin's diseases. This could also be due to ABO mismatch, hematopoietic progenitor stem cell transplantation, where you transplant the wrong, where you transplant the wrong stem cell, and that's kind of a mismatch. And that stem cell will start make the bone marrow to produce the other antigen, and that antigen that is produced is weak. So you are having an extra antigen. So another phenomenon that I want us to discuss is acquired B phenomenon. So in acquired B, the patients either with the bacterial infections and also those ones with colorectal cancer. What happens is that this bacteria will produce a acetylase enzyme. So the deacetylase enzyme will alter the chemical of the terminal sugar of the A antigen. How does it alter that? By removing the N-acetyl group. So once this bacteria remove the N-acetyl group, what you are left with is D-galactosamine. So the D-galactosamine will resemble the D-galactose for the B antigen. And so therefore we are having another false B antigen that is being formed on the red surface of this particular patient. And when you are doing your grouping, it will give you a weak reaction. So this table here gives us an example of a case of acquired B. If you look at the forward typing with anti-A and anti-B, we are having a very strong reaction with anti-A, 4+, and a very strong reaction with, a very weak reaction with anti-B, 2+. However, on the reverse side, there is only a strong reaction of 4+ with the B cells. So according to the forward typing, we are having our patient as AB. But according to the reverse, our patient is, remember it's the same patient, the patient is giving us A. So the reason being, why is it, so the reason being, because in the reverse, you are having a very strong reaction. So that one shows you that it is a true reaction. That is agreeing with the reaction that we are seeing with anti-A. Because if this patient is truly A, then we only expect, on the reverse, we only expect a reaction with B cells. So in this case, the acquired B that has been formed by that enzyme, as we have explained, is the one causing the weak reaction with anti-B and giving us AB in the forward typing. So how do we go about it? So the first thing, you will check the past records of these particular patients, because we have said these are patients who are sick. So it means at one point in their life, they have done blood group, or possibility, if they are cancer patient, maybe colorectal, they have received transfusion before. So therefore, they could be knowing their blood group. So the past records will tell you whether this patient was a non-group A patient. And then next, you check the diagnosis, whether mostly enteric pathogens like the Escherichia coli, those are the ones that will give this deacetylase enzyme. So you check the diagnosis for bacterial infection, cancer of the colon, or rectum. Or you can repeat the procedure using acidified anti-sera. So if you repeat it with acidified anti-B, it will not react with the acquired B. So another good way to solve it, because at least almost 80% of the populations are secretors, you can do a secretors studies. So you repeat the grouping using the saliva, or rather serum. So if you do that, the patient, if they are truly A, they will only secrete the A and H antigen. So they will not secrete the acquired B phenotype. So by doing that, you'll be able to solve. And also you can rule out the presence of autoantibodies. So you test the patient with their own RBCs, as we had explained earlier. And also, if it is a weaker reaction, you enhanced by incubating at room temperature for 15 to 30 minutes. So there's also another anti-sera known as ES4 clone. That is a monoclonal anti-sera, and it does not react with acquired B. So you can also use that if you happen to have it in your facility, and it will help you solve that particular scenario. So another scenario that you're likely to see, which resembles that of acquired B, is for patients who have BA phenotype. So what happens in BA phenotype is that these are group B patients, and they've got extra antigen. So it is the B gene that is transferring a small amount of the A sugar to the H antigen. So that one giving you more of a false, more of a weak A antigen is being formed on the surface of of these patients' red cells. So, and certain anti-A reagents will detect the trace amount of A antigen. So if you experience that, you will repeat the testing with anti-sera from another manufacturer, because it is not, most of them will not detect the A phenotype, the weak A antigen on the red cell surfaces. So you repeat that with another anti-A reagent from another manufacturer, and if it resolves, then that is a BA phenotype. So if you look at the picture, it's more or less the same what we've discussed the other time, where here we are now having the forward typing having very strong reactions with the anti-B, but weak reaction of 1+ with anti-A. So we are having AB, and then we are having B in the reverse with a very strong reactions that is agreeing with the strong reactions we are seeing with the anti-B. So you're having a very strong reaction with A1 cells in this particular scenario. So if this is the case, then that you could be dealing with a BA phenotype. So you just pick another anti-sera and repeat. So for group 3 discrepancies, so we have now talked about group 1 discrepancies and group 2 discrepancies. So in group 1, we said they are due to either a weak or a missing antibodies. And we even cited some of the cited cases like you are likely to see this in patients with hypogammaglobulinemia, elderly patients, or infants. Then in group 2, we talked about either they are having weak reacting or missing antigen. And we have gave a cases of subgroups. We've gave a cases of AB acquired B phenotype and even the BA phenotype. So for group 3 discrepancies now, we are talking about proteins or plasma abnormalities. So these patients, they could be having excess proteins in their system, which are interfering and giving you a false agglutination, or even resulting into Rolex formation, or even resulting into pseudo agglutination. So what do you do? So always don't be in a hurry when you are handling these particular cases in the lab. So be patient and always do not just see this agglutination. We said, the way you've said, resuspend. So in case you are getting this kind of discrepancy like this one for Rolex formation, you need to do add saline, because if you add saline and resuspend it, the saline will disperse the cells, and so therefore the agglutination will not be there. But if it is true agglutination, it will persist. So this one, you are likely to see. So the clinical diagnosis of history is very key, especially when you are doing grouping, not for routine grouping where somebody just want to know their grouping. When you are doing grouping for cross-match purposes or anything to do with transfusion, then it is very key that you always look at the clinical history of the patient, because that will really give you critical information that you need to solve some of the problem that you might be encountering. So you are likely to see this in patients with Hodgkin lymphomas, patients with multiple myeloma, patients with Waldenstrom macroglobulinemia, or patients with increased fibrinogen. So if there is more fibrinogen, small fibrin clot in plasma or in completely clotted serum can be mistaken for red cell agglutinates or reverse grouping. So if you are using serum, please ensure that you are your sample have clotted, so that you don't have those fibrin clots, because they will, when you are doing your agglutination, you might pick them and you will mistakenly read them as agglutination and give a wrong grouping. So it is very key that we follow this. It's just your SOP, because I know these ones are well highlighted in SOP, and also of course due diligence, allowing your sample to clot so that you don't have this bullet number 4. For the rest, you might not really have control over, because the patient, it is a condition in the patient. They are having high fibrinogen, they are having more proteins in their system, like in cases of multiple myeloma patients, and also Waldenstrom macroglobulinemia. You will see the same thing, because these are plasma neoplasms. You will see the same scenario with these particular patients. So there is an example where in our forward, we are having our patient as AB. So if we are having our patient as AB, ideally, we don't expect any reaction with the reverse, because these patients do not have anti-A and anti-B in their system. So just the small table down there. However, in this case, we are having a weak reaction of 2+ in B cells, and also a weak reaction of 2+ with A1 cells. And so therefore giving us O. Reverse is O and forward is AB. So in that case, we want to rule out the possible cause of this particular weak reaction that we are seeing. So one, the weak reaction could be just as a result of the weak reaction could be just as a result of Rolex formation or as agglutination due to the excess proteins in the system of these particular patients. So let's see how to go about them. So the main problem is, if the main problem is due to Rolex formation, this can be solved by washing the cells with normal. So you wash the cells properly with normal saline at least 6 to 8 times. This is the key thing when we are dealing with such kind of discrepancies, because the normal saline, what it does, it will just help remove the cellular proteins. the excess proteins that are being formed. That's what it will do. And confirming it with microscopic evaluation, examination. So if the serum stock reverse grouping is affected, perform saline replacement technique. So in saline replacement technique, I will discuss about that. After centrifuging, you are doing your ABO, blood grouping. So you put your cells, you put your serum. So what you do, or serum or plasma. So those button of cells, you carefully replace the serum or the plasma, and then replace with the that is before you suspend. Then you replace with the saline. Then you resuspend. So if it is a true agglutination, it will remain. But if it is a false agglutination or maybe Rolex formation, it will dissolve. So wash the patient's red cells with saline, and then add a drop of or two of saline to the tube in case of Rolex formation. If the agglutination is true, the red cell clumping will remain. So how do you perform the saline replacement technique in the lab? So you will set up the reverse typing as you normally do. You'll have your A cells, you'll have your patient plasma, B cells, your patient, that's just the way you normally do it. Then you perform the immediate spin, and then before shaking the tubes, carefully remove all the plasma stock, the serum, with a pipette, and then replace plasma with 2 drops of normal saline, and read reaction as you normally do. So as we have said, if it is true that the agglutination is there, it will remain. But if it is just Rolex or proteins, it will dissolve. So principle of this is that if antibody antigen lattice formation has occurred during the immediate spin phase, it will remain undisturbed when you remove the plasma or serum. And this should only remove interfering proteins that cause a false positive reactions. So finally, this is the last group of the discrepancies, and that is group 4 discrepancy. Due to miscellaneous problems such as the patient could be having recent transfusion out of group plasma, as we had given an example with the case of a B receiving O cells, and so therefore you are seeing a mixed field agglutination, a weak reaction and a mixed field agglutination. And then on your reverse, you are seeing very strong reactions. It could be these patients have got cold alloantibodies or autoantibodies. So if it is cold, you do the serum testing at 4 degrees Celsius just to rule out. And also if you do autologous control to rule out autoantibodies. So the autologous control is where you incubate the patient serums in their own cells. Also, these patients could have received a recent infusion of immunoglobulins that could be containing ABO, iso, agglutinin, so giving you pseudo agglutination, or rather false agglutination. So those are some of the things that you can find in the clinical history of the patients. You could be seeing mixed field agglutination with circulating red cells of more than one ABO type, as we have explained. It could be unexpected ABO isoagglutinins. It could be polyagglutination, which is due to exposure of hidden erythrocyte antigens. So some viruses or bacterial would tend to give that. Then naturally occurring or irregular antibodies reacting at room temperature. So like the last case where you are having the patient as B on forward, and then on reverse, you are having the patient as O. However, you are having a very weak reaction that is consistent to what you are seeing with a very weak reaction that is consistent with what you are seeing with the A cells. I mean, with the anti-A in the forward typing, and then on the reverse, it is also very consistent with the B cells. So you have to rule out that. It could be autoantibodies or called alloantibodies that are reacting weakly with these particular cells. So by doing that, you will repeat the testing, but in a warm environment. That is at 37 degrees Celsius. And by doing that, the cold reacting autoantibodies to alloantibodies will be negative. They'll not be able to react. So in resolving cold autoantibodies, false positive reaction in forward grouping can be limited by washing of red cells with, so you can also wash with warm saline. So if warm saline fails to resolve, removal of autoantibody with acid glycine or chloroquine, so those are some of the chemicals you can use instead if you've not achieved to remove the autoantibodies or alloantibodies, in this case, the warm saline. So autoagglutination, that is false positive reaction in reverse grouping, can be resolved by incubating at 37 degrees Celsius for 30 to 60 minutes. So if they are cold reacting, they'll not be able to react at that temperature. And you give it time so that you enhance the reactivity of this particular antibody. Then it can also be resolved by incubating the red cells in the presence of erythritol or 2-mecaptoethanol. So that will also be able to deactivate the cold antibodies. So it's the same thing that we've talked about for cold autoagglutination. Warm saline washes at 37 to 40 of autoagglutinated cells. Pre-warming of serums, you can also use serums that have been pre-warmed, and also reagents that have been pre-warmed at 37. Performing the test at 37 degrees Celsius, most of the autoagglutinins are removed by above technique. And if you happen to have these kind of chemicals, you can add like diethioerythritol can be used to make cells free. And also washed packed test cells at 37 degrees Celsius for around 15 minutes. So having looked at the discrepancies, and we've walked through group 1, group 2, group 3, group 4, and the possible solutions that you can give, or how you can encounter these particular challenges whenever you find one in the lab. So how do you find a problem? Forward type the test for the antigen, that is the red cell, and then you reverse type for the antibodies. So identify what the patient types as in both forward and in the reverse grouping, just like we were doing in the examples that we have used in the presentation. So you look at the forward typing, you look at the reverse typing. Then what is the group in forward typing? What is the group in the reverse typing? And where is the weaker reaction than usual reaction? And where is the where there is no reaction? So things like that. So those weaker reactions than usual, that's how now you'll start questioning which one is giving a false reaction. So you start questioning the ones that are reacting weakly. Then based on the scenario, you are able to, based on the scenario and the diagnosis of the patient plus the age, you are able to deduce and solve this particular discrepancy. So you ask yourself, if they are weaker than usual reactions, is it a missing? So if it is weak, then what is it? If it is forward typing, you'll be asking yourself whether it is a missing, weak, or extra antigen. If it was reverse, then you'll be asking yourself, if that weak reaction is on the reverse typing, then this is the question you ask. Is it a missing, a weak, or extra reaction antibody? Yes, because in forward typing, what are you doing? You are testing for antigen. In reverse typing, what are you doing? You are testing for antibody. So in resolving that, we have said you confirm the patient history, that is their age, check their history, maybe they are transplant patient, they have received transfusion in the recent past, or they could be on medication. So if you are troubleshooting, you read the forward type first, and note the forward type reaction may not be correct. Then look at the strongest reactions. So the strong versus weak reaction can provide the important clues, as we have said. So you'll be able to ask yourself, those weak reactions you are seeing, is it could be a missing, is it could be an extra, is it could be a weak or antigen or antibody. And then anytime you encounter discrepancy of any kind, you repeat the test, number 1, to rule out technical errors. Do not put a lot of headache on yourself before you rule out the technical errors, because you could be doing all these things and it was just a mislabeling, it was just a transcription error, it was just a misinterpretation. So ensure that the pre-analytical is okay and you've analyzed the whole thing and you've ruled out the technical area. So what you are now dealing with in this case So what you are now dealing with is a discrepancy. So if the results are the same, which means you've ruled out the technical error, you've now certified that whatever you are seeing as a discrepant, report it as discrepant. And if it is an emergency situation, like you have to give a blood, you only issue or blood type with or rhesus compatible blood should be issued until the investigation is completed. So in that case, you will cross-match with or rhesus compatible blood. The patient A or B, and it is a discrepant, you don't know their group, because O is a universal donor. And here we are not querying the rhesus system in this ABO discrepancy. So you give, if the rhesus positive, give them rhesus positive. The rhesus negative, give them rhesus negative. But continue with the investigation. And once you've resolved that, then that's when now you can give the patient's blood type. So all discrepancies must be investigated and resolved before the correct ABO type can be resulted. Do not assume that because I'm seeing a very strong reactions in forward typing and a very no reaction in, oh, this patient is AB. Let me give AB and move on. Please don't do that. Do the investigation and rule out. And then if at all you have to give the blood is urgently needed, then as you have said, give the ORS as compatible blood. Investigate, document, have your final report. Once you've agreed on the right blood type, then now you can give the patient's blood type. So finally, we just have a summary. So of what we have discussed, so it could be on forward typing. So forward typing, we said you are testing for cells. So you could be seeing a missing stroke, a weak reaction. Could be due to subtypes like A or B subgroup. The patient could be having diseases like cancers, the example we gave, like Hodgkin lymphomas, and then extra. Could be acquired B. It could be BA phenotype, as we had seen. It could also be Rolex formation, maybe due to excess intracellular proteins in the patient plasma. It could be mixed field. Mixed field could be transfusion with O cells, or this patient could have just received bone marrow transplant, and so therefore there is that warming process when you receive a transplant, and so therefore the bone marrow is trying to produce more of the donor cells. And remember, the patient cells are still there, so you are likely to have a mixed field agglutination in such cases. And then on the reverse grouping, the missing stroke weak reaction due to antibodies, the patients could be young, they could be elderly, they could be immunocompromised. And then it could also be due to extra antibodies, such as cold autoantibodies, alloantibodies, Rolex again, or even anti-A1 for patients who are A2. And then for grading, this is now for lab. This is how a 4+ reaction look like. It's a very strong clot. Even if you try to disturb, it's not breaking. That is a 4+. And then 3+, still strong, but at least disintegrating a bit. And then we are now 2+ reaction, where you are just seeing clots, sparklings of clots, but it's not really in a button like in the case of 4+ reaction. And then in 1+, where almost you can forgo. Maybe you'll have to confirm microscopically, then we'll be able to see agglutinations via the microscope. And then in case of hemolysis and negative, there is no reaction at all. So that's how it looks like in the lab. And that's all. So under our Q&A, we'll look at practice. We'll practice a bit just to learn from what we have discussed, and participants will have a chance to type their answers on the chat or even explain that the next one. Thank you so much, Fred.
Thank you, Francis. It was such a wonderful presentation. I don't know, you can go back to slide number 4. Someone has requested, maybe you can just go there briefly before we go to maybe the Q&A section. Francis?
Yes. Number 2. Number 4, the one for technical errors.
I think
Yes, we
so.
are there.
I think you want to pick something there. So the participant who asked for slide number 4, there it is. And maybe you can just take a minute to see what's there. And then Francis, there are a couple of questions. I don't know what route do we take. Do we go to the practice questions first?
Yeah, we can finish with the practice, then we go through, because at least with that, we would have even solved most of the questions.
Very well. So to our participants, we have a small practice questions for you. And we are hoping that you've been listening to the presentation. And so you will be free to type in your answers in the chat box. This is largely an interactive session. And over to you, Francis. You can go ahead to project the practice questions.
So there we have our first question, Fred. In the forward typing, we are seeing a reaction of 3+ with anti-A. Then we are seeing no reaction with anti-B. We are seeing no reaction with A1 cells on the reverse, and a weak reaction of 1+ with B cells. So to the audience, what could be the problem? We can discuss the cause and resolution together. What could be the problem? Just type in the chat. But you can be looking, and then we see what most people think and go on.
Yeah, to our participants, you can see what has been projected on your slides. And we are just brainstorming. What do you think would be the problem? You can just type in the chat box, and then we proceed. Anyone typing on the chat box on what you think could be the problem on the slide? Okay. Francis? I think Daniel is saying the answer could be called antibodies. Francis, you can hear me?
Yes, I can hear you. I've seen somebody have typed cold antibodies. Maybe you can give one participant a chance.
Any other person? Any other person wants to make a try? Okay, Frank Kibe is saying a gene presenting D-galactose sugar on H protein. Okay, thank you, Kibe, for your thoughts.
So maybe we can just discuss it.
Yes.
There's another.
Is there any other person who wants to share his thoughts?
So if there nobody else, then we can discuss this. All the participants, yeah, we are still having a good number, 500 of them. So in this case, you are doing your normal blood grouping. It could be cross-matching for a patient. So the first thing you have to confirm their blood type. And then we said when you are doing let's refrain from doing just forward typing, and then you ignore the reverse typing, because that's by doing that you'll not be able to pick the discrepancies if they are there. The only way you pick a discrepancies is by doing both the forward and the reverse, so that when they are not agreeing, then you have a discrepancy. Then from there you can investigate. If you just do forward, you'll go with what forward gives you. If you just do reverse, you'll go with what reverse gives you. And that could not be the true picture. or rather could not be the blood type for that patient. So in this case, in forward typing, our patient is blood group A. What do we expect in reverse typing for this particular patient? We expect a reaction with which cells? B cells. Because this patient, if they are blood group A, they are having anti-B in their system. We said the Landsteiner golden rule should always guide you whenever you are doing the blood group. A patient will only have in their system an antibody corresponding to the missing antigen. So we are not having a discrepancy per se, but now the discrepancy is coming in the strength of the reactions. We are seeing a very strong reaction with anti-A. So confirming the patients have got A antigen on their red cell surface, so they are blood group A. And we are also seeing antibodies that are present in our patient, the anti-B, but giving us a very weak reactions with the B cells. So the problem is weak reacting antibodies. So the cause, this likely a case of an elderly patient. So resolution, you enhance the reaction by incubating at room temperature for about 15 minutes, and then you reread. So I think that's clear, Fred. We can move to the next one. Okay. So in the next one, we have question 2. Kindly go through it and type your answer in the chat, team.
Yeah, Dan is saying insufficient volume of the serum. Okay. Any other person? Thank you, Dan Odhiambo, for that. Any other person who wants to share his thoughts? Dan is saying acquired. Okay.
I've seen Rita Cheromo said acquired B. That's good, Rita.
Okay. Boniface Toy saying weak antibodies. Okay. So Dan is clarifying, saying insufficient serum sample was used for the first one, not the second. Okay. Thank you, Dan. Is there any other person? Okay. To you, Francis. George Nyabuto is saying expired reagents. Okay.
I really love the contributions and the answers we are getting. And this means that people have been attentive in this webinar. For the ones who are saying insufficient samples, the expired reagent, now you can see. You said before we said it is a discrepancy, we have to rule out the technical error. So we must go back and repeat carefully, ensure that we follow the procedure, we've used the right volume and all that. Then now, if at all you do that and it is still discrepant, then that's where you are now dealing with ABO discrepancy. So this question, these are now certified discrepancies. We've ruled out the pre-analytical error. We've ruled out the insufficient samples. We've ruled out the expired reagents. We've ruled out the mislabeling errors. But I really love the contribution because the first thing we said, you look at the pre-analytical phase. Was it correct? So you have to ensure that your labeling is correct. You are using the right reagents and they are not expired. So for this case, thank you so much, Rita Cherono, who said acquired B. So this is a case of acquired B. In forward typing, we are having our patient as AB. And then in the reverse typing, we are having our patient as A. However, this our patient in the forward typing, as much as the patient is AB, the anti-B is weakly reacting. Actually, it has a 1+ reaction. And then The we are not seeing any reaction with A1 cells. So the 4 plus, there's very strong reaction, which means this patient have got anti-B in their system, very strong reaction with the B cells. So we are asking ourselves, the problem here is a missing stroke weak, so it is a weak reacting antigen. So this weak reacting antigen could be due to the acquired B, because it is the weak reacting antigen that is causing this particular discrepancy. It is a group 2 discrepancy. So this group 2 discrepancy caused by the weak reacting antigen, in this case is acquired B. So we'll have to go back to the history of the patient and check if they are colorectal cancer or they are patients suffering from bacterial infection, or maybe they have done culture, blood culture, and we have isolated any of the enteric pathogen in this particular patient, not even blood culture. It could be even UTI or something of that sort, yes. So this patient is suffering from a bacterial infection. And we said that bacteria produce an enzyme known as D-acetylase, and it will remove the N-acetyl group, leaving D-galactosamine that resembles the B and the D-galactose for the B antigen. That is what is giving us the weak reaction with the 1 plus. So how do you do this? We said you do the secretor studies, because the patient will only secrete A and H antigen. And another solution that you can do to this is, to rule out this, is you can use the acidified anti-sera that will not react with the anti-B. So this is acquired B. So there comes our question 3. Yes, team. So you can go through it and type your answer in the chat box.
Yeah, you're also free to comment if you want to speak. You can always raise your hand. I will unmute you and you can always comment.
Are we getting some responses on this? Somebody saying increase fibrinogen. So I think I've seen one response. Okay. A good trial on increased fibrinogen, but that will giving us a more of a false agglutination. So in this case, for this particular question, according to the forward typing, our patient is A. We're not having any reaction with anti-B. And then now on the reverse, we are having a very weak reaction with the A1 cells. Then a very strong reaction with the B cells. We are saying that the patient is O. So in the reverse, we are having this patient as O. Then in the forward typing, we're having the patient as A. So remember we said subgroup. So again, this is a case of a weak reacting antigen, a group 2, a subtype case, where in this case, this patient could be A2. And that's why we are seeing, even the A2 patients, they will give which antibody will be present in their system, anti-B, and it will be a potent anti-B, high GM, that react very strongly, the way we are seeing it in the reverse typing. However, the A2 antigen is a weak reacting antigen, giving us a weak reaction with anti-A in the forward typing. And again, in addition to this patient having that subtype, the patient also is sensitive. They have got few anti-A, A1. Now we have to be very specific. Few anti-A1 in their system. So if they have few anti-A1 in their system, giving us a very weak reactions, weak 1 plus with A1 cells in the reverse. So how do you resolve this? You can use the lectin Dutchess by Flores to repeat the test. Because Dutchess by Flores will only agglutinate with A cells. It will not agglutinate the A2. So if you do the forward typing with the Dutchess by Flores up in the anti-A, there will be no reaction because the patient is having A2. I hope that is clear, Fred. We can move to the next. So the next one is we are having the question there. Anybody with a trial on the chart? Boy, people are not responding. You need to respond. As someone got the other one, A2, that was good. Rita Cherono also, I've gotten this one, Rolex formation. Any other patient? Any other person? Fred, you are there?
Yes, please. I'm here.
Okay. So Ochieng was also right. Pseudoagglutination, yes. Yeah. So you can see people at least are responding well, and at least we are getting some good answers.
Sure.
Weak antibodies. Okay. Somebody is also saying recent transfusion. So we just keep your answer for that because we also have a question for that, and it will be very interesting. So in this example number 4 again, we are seeing very strong reactions with anti-A and anti-B in forward typing, and so our patient is AB. And so if the patient is AB, we don't expect any reaction with in the reverse typing because these patients do not have anti-A and anti-B in their system. However, there's a very almost negligible, very weak reactions with the B cells. So this could be just due to piling of red cells, or what we call the Rolex formation, that is giving us this kind of pseudoagglutination, or maybe the interfering proteins. So again, this could be a case of, somebody was asking about, this could be a case of a group 3 discrepancy. This would be a case of a group 3 discrepancies due to pseudoagglutination, a Rolex formation, or just interfering proteins that are there. Maybe the patient is having multiple myeloma. So for Rolex, it's very easy. So you can do the saline replacement technique as we had discussed. Then the saline will be able to disperse the cells. And this 1 plus reactions will go away. Yeah, so this one, the best solution you do is saline replacement, or rather wash the cells with saline for around 6 to 8 times and then repeat. The best. So the next one is question 5. And this one must be easy now. So I'm expecting so many responses because we have talked about it so many times. So I'm expecting so many responses for this for number 5. Thank Mohande. That was good. Cherono is now missing this one, but kind of confusing. So Cherono, you can think again and re-answer. Somebody is talking about expired reagent. Assume the reagent is not expired. So what could be causing this? Muhande is giving us a good answer. Helen Mwaniki, good. Any other person? We are not seeing any agglutination. Somebody's really tried here, immunosuppressed for patients. Juliet Deche, good. Mulongo. Timothy Kiplagat, that's a good trial. Okay, good, Stephen. Good. Ben Ngare, good. Ngare, you've really got it right. That's okay. Good. Kiplagat. Yeah. Mm. Good. Ochieng. Any other person? Yeah. So I'm happy at least with this. So assume the tubes are labeled correctly. Calvin, what could be causing this? Good, Loba. Good. Good. This one, people have done so well, I'm happy with the answers that I've seen. So in this case, we are having our forward typing to be anti-A and then anti-B, no reactions with both anti-B and anti-A. So therefore, this patient is O according to the reverse. So remember, according to the forward typing, sorry for that. So remember, if the patient is O, then they have both anti-A, anti-B in their system. So we are expecting very strong reactions with both A1 cells and B cells. However, in this case, we are not seeing any. So this could be a missing antibody. Actually, it is not even a weak reacting antibody because we are not seeing any reaction. If you are having any reaction, then we are talking about a weak reacting antibody. So the fact that we are not experiencing any reaction is we are having a case of a missing antibody. And thank you very much. Somebody mentioned it here, Ngari. So it could be a neonate patient. They have not yet formed the antibodies in their system, or this could be a patient who is suffering from a gamma globulinemia. They are lacking antibodies in their system. So those are the possible causes for this particular patient. So in such cases, you review their history. If they are neonate patients, then you don't have to do what? You don't have to reverse type. You will go with the forward typing. And if it is a gamma globulinemia patients, then you will have to look at the history. What was their blood group previously? And then apart from that, very key in the lab, because that is now for the clinician. You at the lab, you enhance the reactivity. So they could be having a gamma globulinemia, but very few concentration of antibodies are there. So what do you need to do? You need to enhance the reactivity. You incubate it. That's now the reverse typing. You incubate at room temperature for around 30 to 60 minutes. And then now reread again. Yeah. So that was a good trial for question 5. Finally, we are in question 6. So team, I'm also expecting very constructive and a good participation in this question 6. This is an interesting one. So let's see what people think. So apart from DU, is there any other test for weak D? Yes, you can do molecular typing. Because what DU will does is just to detect where there is where you are having a weak D. And weak D, there are normally those variants of weak D. Kuna partial weak D, and now there is the weak D. The weak D in terms of quantity, the number of the D antigens on the red cell surface are decreased. And so therefore, that's why you are having challenge forming agglutination. So you do the DU test. But now we also have got partial D. Partial D is where some epitopes are missing. So that you can only identify through the molecular typing. Then with the molecular typing, we are able to even get the variants of weak D we are dealing with. So MF there stand for mixed field. MF stand for mixed field. So answers. Fred, is there anybody who have tried this time round for question 6? Very good, Mohande. So people are trying. Good, Mohande. Let's keep the answers coming. Mhm. So there are several questions on CPD point, Fred. You will address. There are several questions on CPD points. Let's just keep the answers coming. I'm just trying to go through to see anything that is general so that I respond to as I'm waiting for your response. Most people are saying they have not received their CPD. So the ones that I'm able to see so far, I haven't seen anything. Okay, let's see the response that people have. Yeah, good. Good, Rita Cherono. Good, Faith Jepchumba. That's a good trial. So let's just keep them coming. So at least this was interactive, and I must say I'm impressed by some of the answers I'm seeing. So this is the most interesting of all of them, especially for those who are actively working in transfusion center or in the hospital setup where you are doing your cross-match a lot for your patient. If you are in referral like Kenyatta, or maybe more teaching and referral, I know you'll be receiving so many patients with different things. The ones who are suffering from cancer, including Hodgkin lymphoma, so you are likely to meet this kind of discrepancy. The ones who have received transplant, the ones who have just received transfusion. Yeah, so very good. So according to this, our patient is having agglutination, or rather a reaction with anti-B in the forward typing. Then anti-A, there is no reaction. However, the reaction is weak in with anti-B and there's a mixed field, which means if you put it under the microscope, some cells are agglutinated, some are not. Yes, so you are able to see cells that are free, so many of them, and then a few that are agglutinated. And then now, because this is a B, according to forward typing, on the reverse, we are expecting only reactions with A1 cells because now they have anti-A in their system. And the reverse is not lying. The reverse is giving a very strong reactions with A1 cells and no reaction with cells. So what could be causing this particular mixed field agglutination we are seeing in anti-B? So it could be a patient who have just received a transfusion. Yes. So somebody was asking about group 4 discrepancies. So group 4 discrepancies, we said that due to miscellaneous. So we have also answered that question here. It could be due to recent transfusion, a bone marrow transplant, a patient having cold autoantibodies or cold alloantibodies. Those are now the group 4 discrepancies. And this is an example of them, where you are seeing a weak reaction in the forward typing with a mixed field. So most likely it's a bone marrow transplant patient or a patient who have received transfusion. So resolution, you look at the history, and once you see that, you will resolve. History, positive history of transfusion and transplant will help you resolve this. So on other hands, you can also enhance the reaction by incubating further at 15 minutes, for 15 minutes at room temperature. Finally, the last one. With the last one, you will really have to rule out the technical error. So you really have to check whether the labeling was correct, whether you put the cells, they were not, especially for the A1 cells. So this mostly a pre-analytical error. So you have to definitely rule out kabisa. Because according to forward typing, we are having O, and we expect reactions to be on both A1 cells and B cells. So before we think of missing or weak antibodies for this case, because there is a very strong reactions with B cells, then we have to rule out whether really was there something added for the A1 cell tube. So this is a clear case of a pre-analytical error. So somebody might have forgotten to add a serum here for the A1 cell tube. So you have to carefully look at that and then repeat. And if that one was done, then you will have to enhance the reactivity for you have to repeat, but now you repeat the whole thing, but now you enhance the reactivity by incubating for 30 to 60 minutes at room temperature. So Fred, if you are still there, we can look at a few general questions, then we will say. I hope the session was interactive and everybody else have enjoyed.
Okay, thank you very much. Actually, it's been a wonderful and exciting topic. I like the engagement and also how the attendees have been involved. So I know more questions are coming in, and I can also see that most of them have been handled accordingly, which is good. For the general questions about the CPD points, this webinar is KML-TTB accredited, and your CPD points will be awarded accordingly, uploaded, and you'll get certificates. At any point that you have not got your certificates or any communication from us, feel free to engage any of our admins in our groups, within our groups, the WhatsApp groups, to ensure. And if you're not on any of our walls, just also reach out through colleagues, or if you have any of our contacts, then we'll be added. And also, if you come across our circulars for webinars, we hold our webinars on Mondays, Wednesdays, and Fridays. So if you come across our WhatsApp invites, there is always a WhatsApp link down there, which you can use to join our WhatsApp pages. So with that, you will be well abreast with our programs, schedules, and anything that appertains CPD provision. For those who are finding challenges, when they try log on to the KMLTTB CPD portal and you find some challenge, ensure that you reach out to KMLTTB. Most of the cases, when you register, your email address that you're supposed to use is the initial email address that you submitted to KMLTTB when you are being registered. So if you don't remember that email address, ensure that you reach out to KMLTTB for assistance. And those who maybe are registered and they forgot their passwords, just reach out to them once again. We do not have any mandate further than that. It is only KMLTTB who can assist. And I think to this end, time has actually gone and we are past time. So any matter that pertains CPD provision, just reach out to any of our admins within our WhatsApp walls. So on behalf of LMSK, I would like to thank everyone for finding time to attend and participate in this webinar. And at this moment, I would like to call upon our presenter, Mr. Francis Awino, just to give a parting shot, a closing remarks, just a few statements on, concerning this webinar, and also anything that maybe you'd like to tell us. Mr. Awino Francis, kindly take over.
Thank you so much. I've seen so many of them are asking about the notes or the slides. Would you maybe address that on how they can?
Okay, good. That's okay. For the notes and slides, we live stream this webinar real time. So when you'd like to maybe revisit something on this presentation, kindly log onto YouTube and then you search the name of this webinar or the title, then you will find it. To make it easier, you can just follow us on YouTube and subscribe on our channel. So on YouTube, you'll find us, our handle is at Lab Medicine Kenya, at Lab Medicine Kenya. So that's our handle, YouTube handle. If you search it, just subscribe. Any all the webinars that we hold are live streamed there, so you will get updates for you to just do your review. So that is put like that so that there is universal access to all our webinars. Maybe documents shared might be limited to maybe a small number of people or a small group, but the entire presentation on YouTube will exist on YouTube as long as LMSK exists and the world is still running. So thank you very much. I think that is well handled. Over to you, Mr. Francis Awino.
Okay, thank you so much. And so the parting shot is that at the end of this webinar, I know blood grouping is a people look at it in a very small angle. But from this webinar, at least we've seen that there is really a lot that comes with it. And if it is done properly, we are able to pick some of the discrepancies and we might avoid errors. Because again, if we fail to pick these discrepancies, we'll, like for example, a case of acquired B, you will be doing forward typing and then you give an AB blood. But remember, these patients are colorectal cancer patients. You've given them an AB blood when truly it was just a discrepancy because you missed the reversed. You could not pick that particular discrepancy. Few minutes later, the patient is reacting to the blood. Why? Because they are blood group B. They should only receive blood group, a donor with blood group B, and those ones of blood group O peke yake. So such kind of cases. So to avoid it, they are blood group A, yes. So such kind of cases, to avoid such, let's just do both reverse and forward typing. And then now we are able to pick this discrepancy. You might not really appreciate this if you are working in a setup where most of the blood grouping is routine, maybe through MC or someone just want to know their blood group. These are people who are physically fit, they are healthy and all that, so they don't really have so much issues with them. But if you are working in a referral setup where you are dealing with the immunocompromised patients, you are dealing with bone marrow transplant patients, you are dealing with multiple transfused patients, we are dealing with cancer patients, you are likely to find this particular discrepancy. And we've seen how important it is, because if you don't resolve the discrepancy, you will give a wrong blood type. To give
That's
a wrong,
wonderful, Mr.
yeah.
Francis.
Yeah.
We really appreciate this presentation. It's indeed been wonderful. And I can see quite a number appreciating. Dan Odhiambo is saying that it has rekindled his memory when he was in Cambridge. And quite a number of appreciated, and they're saying that it's a wonderful presentation. So to this far, and on behalf of LMSK, allow me to once again say thank you for finding time to join, finding time to participate, all the members, and also to our presenter, Mr. Francis. We really appreciate your time and wealth of knowledge, and also being in a position to share that knowledge with the rest of the medical laboratory practitioners. So allow us to now come to an end. And to this far, I wish everyone a lovely evening. Thank you.